Hello everyone, my name is Simon, and first of all I would like to extend a thanks to both Barbara and Mel for organizing this great conference. Just to restate, my name is Simon Mark Dahl Baunwall. I'm a medical doctor at the Department of Hepatology and Gastroenterology at Aarhus University Hospital, and furthermore I'm a PhD graduate at the Department of Clinical Medicine at Aarhus University. My primary field of research is within the field of fecal microbiota transplantation and all the elements surrounding this, ranging from the donation part to the processing part to the clinical application hereof. And I sought to sort of grab to all opportunities to advocate for the treatment and especially stool donation as something with life-saving capabilities when used for fecal microbiota transplantation, or for short FMT, where FMT in the later years has come to become an important treatment that is heavily dependent on donors, and that is something I will return to. But just to get at the basic, it's about stool, or the transfer of stool from a healthy individual to a diseased recipient with one intent, and that's the intent of transferring the content of the stool, which we coin the intestinal microbiota, which composes both bacteria, viruses, fungi, parasites, and also donor-derived substances of human origin, of course. And we do this with one overall aim, which is to reestablish correct a depleted intestinal microbiota in the recipient that we believe is contributing either directly to the disease or indirectly to the disease manifestations. So just in essence, the whole meaning of performing an FMT is to achieve health benefits and gains in the recipient. So if we compare this to another very common treatment approach of targeting the intestinal microbiota, that being antibiotics. The antibiotics aim to deplete the whole ecosystem in that sense, whereas FMT, on the other hand, is more of a restorative nature that aims to correct or re-establish a normal intestinal microbiota by the use of another healthy microbiota. So what started the use of using fecal microbiota transplantation as a therapy? Well, it's really gained traction in 2013 with this study published in the New England Journal of Medicine from the Netherlands group that demonstrated that duodenal infusion of donor feces for recurrent Clostridium difficile was a highly effective treatment. And if you look to what is Clostridium difficile, well, it has since been named to Clostridioides difficile, but it's still the same bacteria, and it causes symptoms when infective and not asymptomatic, where it's just a healthy carrier state. It manifests as symptoms ranging from diarrhea to pseudomembranous colitis, fulminant colitis, and even death. It's mostly seen in the elderly population following exposure to antibiotics that has created this disruption of the intestinal microbiota. We have later been able to worldwide to reproduce this result in following trials, and what we have found for the indication of multiple recurrent C. diff infections, that being not the first, neither the second, but 3 infections or more, patient that receives FMT following a course of vancomycin or other antibiotics seems to have a high effect of around 90%. And if we look to other benefits in terms of mortality, it also seems to improve the mortality and the prognosis of the patients receiving FMT. If we compare FMT following vancomycin to vancomycin monotherapy alone, the number needed to treat is around 1.5, which is a pretty dramatic effect, and probably the main reason for FMT now entering the clinical treatment recommendation of the clinical societies worldwide. If we look to how FMT is administered, there's 3 main application forms for FMT. The first is colonoscopy, which we until now considered go-to standard as it's also diagnostic. But some patients may not be able to undergo colonoscopy, and in these patients we prefer another administration form that could be the nasogeographic tube insertion, or the more emergent therapy form that is encapsulated FMT, which also make the treatment highly scalable and available to the patients. But if we are to consider when is FMT used besides the DIF, there's a lot of ongoing trials, some that has been published and even more that is still ongoing, and promising results actually indicate that FMT may also be a promising treatment for multi-resistant bacteria, inflammatory bowel disease, and also IBS, hepatic encephalopathy, and many more. So this brings us to a question for the domains of FMT. How do we secure the treatment? And this can actually be divided into 3 overall domains that are of equal importance. We have now touched upon the clinical application and why we do and perform FMT in the first place. But then there's also the aspects of donor recruitment and selecting the right donors, and also the laboratory processing. For the remaining of this presentation, I will mostly focus on the donor recruitment because there's really a lot of aspects to cover, and they are really vital in securing the treatment. And one of the main questions that remains is, how do we find people to donate their stool for therapeutic purposes and FMT? So how do we find the right donors? Well, for recruiting donors or people, it has been found that if you go to the general community, around half of the population is actually willing to donate their stool for therapeutic purposes. And for these that are willing to donate, most are actually willing to donate up to twice weekly. Another important aspect you could say that is interesting in increasing the willingness is donor education. That is, advocating the treatment to the general public so they gain a knowledge of its existence in the first place, but also the therapeutic benefits. And if we look to donors that are already donors, or people that are already donors, we found that, or it has been found that blood donation increases with willingness to donate feces as well. When we examine what are the reasons and the motivations for donating, around 40% is purely altruistic. That meaning they want to benefit another human being. And around 60% is also with the main altruistic purpose, but also have a part of an economic incentive. In this instance, we mean that they believe they should be compensated for some of the donation because they use the time on doing so, which is a logic rationale for donating, because it takes up some time. And if we examine further, what should the compensation per donation be? Well, around, again, 30% found that donation should be voluntary. Around 36% think that around $1 to $30 per donation is fair. And another 36% found a compensation of above $21 should be considered. And what I also think is quite interesting is younger people seems to favor compensation. But now we know that around half of the general community is in the first place willing to become feces donors or stool donors. But how many of these donors is actually able to become eligible donors in the first place? Well, we have to look to the screening and the screening requirements of stool donors, which is quite comprehensive to be honest. And I have just taken a snapshot of some of the screening panels needed to be examined before deeming a potential donor eligible for donation. This includes age criteria. They have to be in good health. They should not have been exposed to antibiotics in the previous 3 months. And in the last 6 months, they should not have had high-risk behaviors. And if you just look to the more objective in blood screenings, they should undergo a quite comprehensive screening panel here. And then for the stool itself, we have to exclude the presence of known pathogens. This could be enteropathogenic E. coli, Clostridium difficile or Clostridioides, Campylobacter, Salmonella, Shigella. Then there's also the multidrug resistant organism we have to exclude the presence of, viruses, and parasites. So just to summarize, this is not even the whole panel, and it's in constant update. But when considering the screening panel for stool donors, we have to now consider the route of transmission. There are some bacteria that only is transferred through the gastrointestinal tract, but it also has to be updated with the current infectious pressure with the COVID. And some of the risk factors is actually quite broad, and some risk factors is new to the known screening panels of other substances of human origin. And when we just have to say something general about the screening of the donors, well, we lack evidence for most of the screening content, and most is consensus-based and based on international expert experiences. And again, the risk factors is really broadly defined, so no travels, no, for instance, family history of inflammatory bowel disease. And some of the screening panel, some of the parameters included in the screening panel is actually mostly theoretical. So this leaves one vital question. We know half of the society, people in the general population, is willing to donate the feces, but how many of these people are actually able to become stool donors in the end and go through all the screening? So where do we find such people? And we have examined this quite thoroughly, and we have a hint in that we found that blood donation increases the willingness, and the rationale for using the blood donors is actually they have already been willing to donate one thing, and they have also undergone quite an extensive screening just to become blood donors. And if you look to the basic characteristic of a blood donor, it's evenly distributed with both female and males. The age is okay. Their BMI is probably to the higher side, and understanding that for stool donors the maximum is actually 28. So if we go to blood donors and ask them, do you want to become a feces donor? Well, how many would then say yes? We have examined this, and what we found is that actually most of blood donors say yes to undergo the screening to become stool donors if they can fulfill all the screening criteria. It's only around 12% that decline the participation to the screening program and start all the screening to see if they are able to undergo the screening. Of the people stating that they want to become stool donors if possible, well, most actually fail the initial screening in the questionnaire. And the main reasons for this is they have allergies or a BMI above 28. And this, you could argue this is problematic, but right now the precautionary principle states that this is exclusion criteria, and this is something we have to look into further in the future to see if this is actually some criteria we have to use. But also there's actually quite some interesting part on the gastrointestinal symptoms, because all the blood donors asked in the study was actually active donating plasma or blood at the time, and had stated before entering the study that they were feeling well today. And what I found pretty maybe concerning was that actually 5 of the 155 screened donors reported that within the last 4 weeks they have seen blood in their stools. And when asked if they have seen it, it was something they considered just to be normal. We could tell them otherwise and tell them to see the doctor, but when we then screened the 48 potential donors from the questionnaire eligible for the further test of both blood and feces, well, we saw that some tested positive on parasites that we actually didn't know was prevalent. For instance, Intermoeba coli and Intermoeba dispar was a common finding, but also adenovirus and cytomegalovirus. And in the bacteria department, we found one ESBL producing E. coli. But around 10% of the donors were excluded on the basis of the blood and fecal screening, indicated that, okay, they donated their blood at the time or the plasma, so we would also expect that they were not positive on most of these parameters. When we then had all the screening results, we found that we had to exclude some potential donors, either because lost to follow-up, that despite our efforts to keep in contact, we just lost the contact. And then on our part, we had some procedural screening errors that precluded us from correctly stating if they could become stool donors. This is, of course, something that we could improve on, but I also think that the donation programs has to be designed to meet this, that you actually have to have quite some infrastructure around the donors and all the screening before enrolling the first donors. But just in conclusion to this, we found that approximately every fifth blood donor is eligible. And because of the time of the screening and the needed time to just find one, we spend currently around one and a half hour to just find one eligible donor. But when we have this eligible donor, that just means that they are eligible to become active donors. And then there's a new set of parameters that becomes important, because they are eligible, are they stable donors? Are they able to come maybe twice a week, or just once weekly, or bi-weekly? And can we retain these donors? And what about the screening status? They have been able to pass the screening once, but are they able to do this repeatedly? This is something requires quite an extensive donor program, and we are looking into this because we have some of our donors that later fails, or we have some retention problems, or we have some that is very stable, but just because they are stable, are healthy the same as stable. This is some aspects we have to address in future studies, and that is really warranted to just design the infrastructure needed to provide FMT. And then there's the ethical consideration of donating feces, because what does stool donation actually imply? Well, there's some ethics we have to consider, because we subject, even in our instance, blood donors to an extensive screening panel. And if we just have some incidental finding in the screening that renders the donors able to just donate the blood as they are used to, or even becoming patients, we have to consider this. And this is a borderline that we really had to consider, because these people identify themselves as healthy individuals, and we should not make them sick just because we have to screen them to become stool donors. And then again, some of the screening panel contains some pathogens that we actually don't know the pathogenesis of in healthy individuals. We also have to acknowledge that the current diagnostics is tailored to patients and not healthy donors. So when we ship samples to a microbial department or the biochemical departments for testing, they have been calibrated for patients and not healthy donors. And at a more general level, we really have to avoid the exploitation when donors can donate indefinitely. We don't have a maximum donation, because if a donor goes to toilet twice daily, they could potentially just deliver twice daily. But we have to set some boundaries for how often can you donate, because otherwise we will end up with a situation where the donor feels a pressure to donate, and a donation has to be voluntary and not be dependent on some pressure to donate. And another really important part, that is the financial gains. We have to first of all avoid that humans become subject of trade. For instance, if a donor is really active, we can end up making the donor financial depending on donations. So if, for instance, they receive $25 compensation every time they donate, well, they may end up in the end of the month becoming financially dependent on donating. And if we, for instance, find a super donor that is performing better than all the other donors, is it then ethical to just only use this donor and continuously make them donate instead of other donors? This is something we really have to be very cautious of, and the donation programs really have to avoid making such mistake that may be considered unethical to the donors. And then there's a whole area of safety. And this is actually a case from 2019 in the FDA in the United States put forward a safety alert regarding the use of FMT because of two serious adverse reactions. That was the transmission of multi-drug resistant, or in this case ESBL E. coli, to severely immunocompromised patients. And one of them unfortunately ended up dying from the ESBL infection. What this really resembles is the early days of the blood donation, where this case was the first reports of acquired immunodeficiency in an infant that was possibly transmitted by the means of blood products. And what this is actually the first report of HIV, which we later have come to understand that was able to be transmitted by the means of blood. And that we later have found that by instating some really safe protocols for both screening and quality, we have been able to reduce pretty dramatically. And as for FMT, we have also found that if we apply high safety standard and rigorous quality standards, we are able to reduce this risk to a minimum and actually precludes donation that, for instance, contain MDROs. But I actually think that as for all therapies, and when we intervene on patient and prescribe a treatment, we have to consider the severity of the disease entity, because especially with FMT, with some of these safety concerns, we have to consider if this is a mild disease, we should probably rethink the indication for using FMT. But on the other hand, for the instance for C. diff, where there are limited treatment options and it's associated with a high mortality, FMT is really indicated. But just about the safety, well, what do we know? We know that FMT seems to be well tolerated on the short term, because it's a quite novel treatment, or it's not a novel treatment in that sense, but since we really have started using it in 2013, we don't have the long-term experiences of above 30 years. But what we know is we are currently forming large multi-center databases to just follow up on the safety issues. And we are applying very high safety standards, and we have shown that if we do so, we can reduce the risk. But a thing that's also for the future is to address if most of our current experience is with C. diff, but when we change indication, do we also change the safety profile of FMT? This is something we have to, of course, register. So, what have also been the last few years' developments in the area of FMT is the formation of stool banks. And because FMT actually resembles the early days of the blood centers, most of the experience can be transferred directly, and it really resembles the early histories. And what we have seen is that worldwide several stool banks have emerged to meet this demand for safe FMT. And what are the main benefits of the stool banks? That is actually, it allows for a high volume of stool donors within the stool programs that can be considered ethically, because we don't have to use only 2 or 3 donors. We can now use multiple donors without the big problems, and the large logistics that is required to handle this operation can be centralized, and it enables us to just follow more strict safe procedures and quality standards. When we start to centralize things, the operation becomes more scalable, and it enables for clinics that would not have had the infrastructure needed to establish the programs to perform the treatment. So it's just a really essential idea to just make stool banks and the formation of stool banks, and differentiate between what is a FMT clinic that just receives suspensions or preparations from a centralized stool bank to FMT centers that both perform FMT and also screens the donors and the process themselves. And I actually think that the conclusion of the recent UAG journal from the UAG working group on stool donation and FMT, and it stated in the conclusion that the implementation of fecal microbiota transplantation by stool banks in concordance with our guidance document will enable quality assurance and guarantee the availability of donor feces preparations for patients. So in essence, we are able to, by formation of stool banks that follows this guidance document, will help prepare safe FMT preparations capable of widespread dissemination. Another very important aspect of FMT is how it should be regulated in practice. Is it a tissue, or as a tissue transplant? Is it a drug, or is it both? And how do we regulate FMT to ensure safety for the patient and the donors? And this is something that has created a lot of controversy around the world. For instance, in the United States, an FMT is considered a drug. In Europe, some countries states it's a drug, some countries consider it a tissue, and in some it's unregulated. And it's really, because due to the novelty of the procedure, it's really hard to tell what is the right legislation. I argue that FMT should be considered both. That meaning, because FMT comes from a donor, it's uncontestably a tissue until it does become something else, for instance, an advanced medicinal product and therefore a drug. But it's about striking the right balance that ensures the access to the treatment for the patients and ensures patient safety, but also, this is important, enables for innovation of the area. And the thing we really have to keep in mind is the donors and the protection of donors, because if it's only considered a drug, the legislation doesn't cover the donor aspects. And we really need to be sure that it covers the donor-recipient connection and the traceability needed, but also really keep in mind that humans should not become subject of trade. And then there's the potential of FMT. And currently, this is only data for Europe, and in the United States there's a centralized stool bank providing for all of the United States, and I know there's also quite an operation in Australia and in China. But just in terms of potential, what is the potential for using FMT? If we look to Europe, well, FMT centers and stool banks has emerged all across Europe. And in 2019, we estimate around 2,000 total procedures and 1,100 procedures for CDI. And currently there's above 100 clinical trials. And if we put this in context of the indication for C. diff, that is multiple recurrent C. diff, we know that with the current number of cases of C. diff with multiple recurrences in Europe, the current usage of FMT covers around 10% of the patient with indication. This leaves quite a room for improving and just scaling the operation of the stool banks to provide for the patient and inform the clinicians of the possibility to perform an FMT. So if we look to the future of FMT and just stool banks and stool donation as a whole, maybe this stool donation is a new frontier for blood centers that has existed for centuries and proven their worth in reducing risk when handling tissues and substances of human origin. And when using blood donors for stool donation, we are able to scale the FMT operations more easily and provide for all the patients with indications potentially. Another thing about FMT that I have not discussed is the mechanism of action, which currently is unknown. We have some ideas to what may be the mechanisms of action, but we don't know yet. And it's probably dependent on the disease entity, and in other diseases rather than C. diff, maybe there exists a donor-dependent effect that we don't know of yet. And of course, we always have to consider safety, because it remains the main concern and the potential drawback of FMT. But what we have found is that safety standards similar to those applied for similar substances of human origin, that's sperm, egg, blood donation, milk, for that instance, reduces risk to a minimal. And what we need currently is long-term follow-up to see if this observation of long-term effect or no serious adverse events holds true, for instance, in 10 years, 20 years, and even 30 years. This was my presentation, and thank you for tuning in. Unfortunately, I'm not available for questions following this presentation, but you are very welcome to direct a mail to me anytime. Thank you.